Hello, everyone. Thank you for joining today's live surgery broadcast. I'm a Professor Soo-Hwan Byun. It's a great pleasure to be here with you on today's live broadcast for live surgery. Today's live surgery is taking place on Friday, September 19th, 2025. I'm a moderator and operator of today's live surgery. Today's case is minimally invasive anterior implant placement using Bright Tissue Level Implant. We will be focusing on less invasive approach to achieve a successful outcome in the anterior area. Let's start with the patient information. The patient is 53 years old male. His past dental history includes the extraction of his upper and lower teeth due to periodontitis. His chief complaint was he wants implant treatment for his upper anterior area. He has a pre-diabetes condition and a history of NSAID hypersensitivity. Based on patient condition, our surgical plan is place two Bright Tissue Level implants on upper anterior area. We will use Bright Tissue Level implant, diameter 2.5 and 3 diameter fixtures. We will also perform bone graft if there will be exposed part of the fixture on labial side. Their upper photo is the preoperative panorama, and the lower photo is the preoperative intraoral images. You can see that the ridge was thin, and the bone in the CBCT images, the ridge width was narrow, and in this situation we can use the 3.6 millimeter or 3.5 millimeter diameter fixture, the conventional fixtures. So in this case, I decided to use the Bright Tissue Level implant 2.0 or 2.5 or 3 millimeter diameter. In today's case, I am using OSTEON Xeno. It is a xenograft material. It is a bovine cancerous bone with a microporous structure, and the organic matter has been completely removed. It also has excellent hydrophilic properties. So in most cases, I'm using the OSTEON Xeno bone graft material to cover the exposed fixture or augment the anterior upper area or the anterior lower area. Next, I will talk about the Bright Tissue Level implant. Bright Tissue Level implant is narrow but strong. It has a high compressive strength. You can see in this chart, small diameter tissue level fixture can be placed without concern of fracture. This allows for a durable solution even in narrow cases. We can use 3.5 diameter tissue level fixture in molar area, 3 millimeter diameter tissue level fixture in premolar area. Especially in anterior area, we can use 2.5 or 3 millimeter diameter tissue level fixture. It is very useful in narrow and short cases. The Bright Tissue Level has a 3.8 single platform. It provides an excellent emergence profile for anterior and posterior restoration. It also has a 20 degrees external taper connection. It provides good stability and a hermetic conical sealing effect, as well as aggressive thread design. It ensures the strong initial stability even in the improper bone quality situation. So thanks to the design of Bright Tissue Level implant, we can place the implant after extraction immediately. There are a total of 7 different diameters: 2, 2.5, 3, 3.5, 4, 4.5, and 5 millimeter. I mostly use the 3 millimeter to 4.5 millimeter diameter fixtures, and rarely use 2 millimeter, 2.5 millimeter, and 5 millimeter. I'm using 2.2 and 2.5 millimeter fixtures in anterior area. There are also 6 lengths: 7B, 7, 9, 11, and 11, 13, and 15. 7B, in tissue level fixture, 7B has 1.5 millimeter bursting surface at upper area and 5.5 millimeter SL surface. So we can use 7B tissue level fixture as 5.5 millimeter length fixture. So we can use it in the posterior area without sinus augmentation, and we can use it in atrophied posterior mandibular area. Before we begin today's live surgery, I would like to show you a similar case of implant placement in the lower anterior area. In this case, this tooth was hopeless, so I decided to remove and place a single implant in this place. This is a clinical photo after 2 months from extraction. The ridge is narrow and thin, so I decided to use 2 millimeter diameter tissue level fixture. I opened the flap minimally, as minimal as possible, and I placed 2 millimeter Bright Tissue Level implant, 2 by 11 millimeter fixture. Most of the fixture was exposed, so I covered the exposed fixture site with OSTEON Xeno, the bovine bone graft. And after that, I cover the fixture with the 40 Defilon sutures. This panorama is post-operative panorama X-ray, and I connected the final restoration after 2 months, and the implant fixture was positioned so well, even in a narrow space. I was able to make a SCRP type prosthesis in this area. In this case, single restoration in lower anterior area, we can use 2 millimeter or 2.5 millimeter with a minimal invasive surgery. It can broaden the indication of implant treatment in anterior area. Okay, let's move on to today's live surgery. I'm an operator of today's live surgery, and I'm also moderator of today's live surgery. Start with incision, cluster, and circular incision. In this case, the soft tissue, periosteum, and the gingiva thickness was too thick, so it was very difficult to elevate the periosteum and soft gingiva from alveolar bone. I did the additional incision on the periosteum. I prefer to use the number 9 periosteal elevator for periosteal elevation. In implant surgery, it is very essential to expose the palatal side of the alveolar ridge to identify the ridge width and the condition of the alveolar bone. In spite of thick gingiva, the thickness of alveolar bone was very thin. So after periosteal elevation, I decided to use Bright Tissue Level narrow implant fixture. As you know, in anterior area, sometimes we need to do additional injection for pain control. We replaced 2 Bright Tissue Level implants at right central incisor area and left lateral incisor area. I'm removing the granulation tissue around the drilling site. The granulation tissue can hinder the drilling procedure of implant placement. So it is very essential to remove the granulation tissue prior to the implant drilling. I usually use the implant drill with extension drill because the adjacent teeth can be an obstacle to approach the drilling site, the extension drill can prevent the kind of situation. This is a 2.5 millimeter bright drill. Whenever I do the implant drilling in anterior area, I check the drilling path during the drilling. It can increase the accuracy and stability of implant placement for proper occlusion. I decided to use the 3 millimeter diameter on right side. So when we use 3 millimeter diameter fixture, we have only two chances of implant drilling. And when we use 2.5 millimeter fixture, we have only single chance of implant drilling. So we should be cautious of accurate implant drilling when we use a 2 millimeter or 2.5 millimeter or 3 millimeter diameter tissue level implant fixture. I'm placing the 2.5 millimeter diameter bright tissue level implant on left side. On right side, I'm placing the 3 by 11 implant, bright tissue level implant fixture. Initial stability of both fixtures was very good. For deeper fixture placement, I used the hand latch. I will use the comfort cap after removal of mount screw in tissue level fixture. I'm connecting the comfort cap. Due to the thick gingiva, it was a little bit difficult to connect the comfort cap into the fixture. The diameter of the comfort cap was 3.2 millimeter, the narrow one. We can use 4 millimeter diameter comfort cap in the wide case, in the premolar or the molar area. The insertion torque of both implant fixtures was more than 13 Newton. I'm preparing the bone graft materials to cover the exposed implant fixture, the both side. I'm using OSTEON Xeno bone graft material. The bony defect of both sides was concave design, and the soft tissue, the gingiva thickness was good. So in this case, I did not use the collagen membrane to cover the grafted bone. But when the bony defect design is not ideal or the gingiva thickness is not good, in those cases, I prefer to use the collagen membrane to cover the grafted bone. However, if you want to enhance the success rate of the bone grafting procedure, in such cases, you can use the collagen membrane to cover the grafted bone additionally. Okay. Implant placement, implant fixture placement, and bone grafting were done. So I'm doing the suture around the surgical site. I always start the suture in the key point area. In this case, the grafted bone site is the key point area. So I started the suture around the grafted bone area. I prefer to use the interrupted suture around the fixture. Proper interrupted suture can be a good tool to finish the implant surgery very successfully. In this video, I'm talking about narrow implant system with my resident. My resident told me 2.5 millimeter or 3 millimeter fixture is too narrow to place in anterior area. So I explained about the strength of the tissue level implant design, and we can use 2.5 millimeter and 3 millimeter diameter implant fixture in anterior area. All right, everyone. That concludes today's live surgery. Thank you for following along with us. We are going to take a brief break. During this time, we can scan the QR code to submit questions. When we come back, we will show you the patient final result and answer the questions. See you in a few minutes. Thank you. Okay, let me show you the post-operative result. Here are the post-operative X-ray images, and we can see the two bright tissue level implant in upper anterior area. We use 3 by 11 fixture on the right area, the right upper central incisor, and 2.5 millimeter by 11 millimeter bright tissue level fixture on left upper lateral incisor. We did minimal bone graft on labial exposure site, and we can see that the both fixtures were well positioned in alveolar ridge area, and I will talk about the entire process of the implant placement and bone grafting in today's live surgery. We used two bright tissue level narrow fixture on both sides, and I did the minimal periorbital elevation. Even using the bright narrow tissue level implant, the upper part of the fixture was exposed. So I did the bone grafting to cover the exposed area. I used bovine xenograft, OSTEON xenograft to cover the exposed site. And after that, I connected the comfort cap after removal of mount screw. And total surgical time was less than 15 minutes. And thanks to bright tissue level narrow implant, the minimal invasive implant surgery can be done. This is the clinical photo after 2 weeks. At this time, I did the stitch out, the stitch removal. The soft tissue condition around the both fixtures was very good. And after 2 months, I decided to make the final restoration. This is the final prosthetic result. The final prosthesis was made with a rainbow multi-layer block. After the milling procedure, pink porcelain was added due to the atrophied ridge. We can cover the atrophied ridge to use the pink porcelain, the adding pink porcelain on the Zirconia block. Now, let me show you the questions. We have 2 questions. The first question: why did you choose to use the OSTEON Xeno instead of OSTEON Xeno collagen in the anterior area for this case? That's a very insightful question. OSTEON Xeno collagen is made of OSTEON Xeno and collagen. The primary reason for choosing OSTEON Xeno in this case comes down to predictability and aesthetics. The both factors are very critical in anterior area. In the anterior area, it is essential for the exposed part of the fixture to be completely covered by bone graft to ensure a good aesthetic outcome. While OSTEON Xeno collagen could also be used, the absorption rate of OSTEON Xeno collagen can be difficult to predict. So in this case, to make the proper, safe, clinical aesthetic predictability, I used the OSTEON Xeno bone graft material. The second question: when do you use a 2 millimeter diameter tissue fixture? I'm using the 2 millimeter diameter fixture in a very thin or narrow rich case, specifically in anterior mandibular area. Thanks to 2 millimeter this tissue fixture, it has expanded the range of implant treatment indications and improved patient satisfaction. The 2 millimeter or 2.5 millimeter diameter can reduce the patient discomfort and the bone graft procedure. It can reduce the total fee of the implant treatment, and it can reduce the entire implant treatment time. It can increase the patient satisfaction. So I highly recommend to use 2 millimeter or 2.5 millimeter tissue fixture in anterior area. Okay, that concludes today's live surgery. Thank you so much for watching and for your valuable questions. Our next live surgery on Friday, October 17th, 2025. We hope to see you then again. Thank you.